is my honor and pleasure to introduce Dr. Risheng Xu. He is one of our senior residents at Hopkins and a close mentor of mine and neighbor. Dr. Xu is a PGY7 resident at Hopkins, having graduated from their MD PhD program. He is interested in open cerebrovascular and endovascular and has been completed his enfolded fellowship. He's going to actually be joining our department as an attendant after he graduates. Risheng is a star and has always been a star. And obviously, you guys saw the flyer. He's got a lot of awards, and his research in stroke and aneurysms have been pioneering for us in neurosurgery at Hopkins and beyond. So it's really a pleasure to listen to this lecture and to have him give this lecture today. I'm excited to learn because I always learn from him. So I'm sure you guys would learn as well. But I'm gonna go ahead and let him take off.
Thanks so much, Nancy. It's only partially true, but Nancy and I are very good neighbors, actually. And we're often so busy. We oftentimes remind each other when we have to like pull up the weeds in our backyard. Otherwise, we get like fined by the homeowners association. But thank you so much, Nancy, and thank you so much for the invitation, to come and give a talk. And as Nancy indicated, I'm joining the faculty member as a cerebrovascular faculty member, and so when I asked, what would be the best thing to talk about and what would be relevant, we thought a little bit about sort of where kind of everyone was, in their training in terms of like, medical school, residency, that sort of thing. And so the goals of today are just to really like introduce some major developments that have occurred in stroke care over the course of the last 5 to 10 years, because there's been a major transition, and really kind of catch, to at least put it on the map for everyone here, to make sure that we kind of understand how that care is changing very rapidly. So let me just share my screen really quick. Can you guys see my screen?
Yes, we can.
Is he okay? Good. All right. So let me. And then how about this? Is this the full screen now?
Yeah, perfect.
Okay. Now, so today I thought I would talk a little bit about advances in ischemic stroke care. I have no disclosures. And so I thought I would talk a little bit about the epidemiology, the pathophysiology, and kind of where we have been traditionally and what the limitations of that are. And, really talk about in the last couple of years how endovascular neurosurgery has changed the landscape of stroke care, and kind of, lead you guys into thinking about potentially what might be sort of the future directions of stroke. And so just a little bit of background, about me. I'm currently a PGY7, as Nancy has indicated. I grew up in Houston, Texas. I did my undergraduate at Harvard College. I studied organic chemistry and organic synthesis there. I did an MD PhD at Hopkins under Saul Snyder, where my PhD was really like focused in pharmacology and neuroscience. And right now, as I join the faculty, I'm a cerebrovascular faculty member, and my areas of sort of where I do research and where I, in terms of patient care, is kind of, trigeminal neuralgia, which is kind of like vascular compression of, cranial nerves, ischemic stroke, moya disease, hemorrhages of various sorts, and then always, intracranial hemorrhage of any kind, especially as it's found in trauma. So, I think it's important for us to realize that, no matter what it is that you go into in terms of medicine, that you will always encounter someone who is going to unfortunately suffer from ischemic stroke. Globally, stroke is the second leading cause of death. And in 2016, the incidence of stroke globally was 80.1 million. And the vast majority of stroke, around 85% are ischemic stroke, which is caused by the lack of blood flow to a certain area of the brain. And then the other 15% are hemorrhagic stroke. And, to talk to the point about how stroke has changed, 50 years ago, it was kind of the high, income countries that were sort of disproportionately affected, by ischemic stroke. And over the course of the last 50 years, as primary care has really come to the forefront in the Western Hemisphere, the incidence of stroke actually has progressively declined to the point where actually in America today, stroke is actually only the sort of third to fifth cause of mortality, depending on how you count, basically. As opposed to the second leading global cause of death. And really, the highest burden of disease is actually in low and middle income countries. And that's really due to the prevalence of sort of, highly processed foods, and foods that are convenient, if you will, but unfortunately are not all that healthy for you. And, the incidence of that is obviously very strongly associated. Oops, sorry. I need to go backwards. And so the incidence of stroke is strongly associated with modifiable risk factors, right? So hypertension, hyperlipidemia, smoking, diabetes. I mean, these are all kind of diseases that are best addressed via primary care, right? And so if you look at the epidemiology globally, right, you see that actually where the incidence of stroke tends to be the highest is absolutely the middle and the low income countries. And over the course of the past, half a century or so, the Western Hemisphere has progressively decreased, the burden of disease of stroke. And so, I thought for today's talk, it might be important to look at the stroke statistics on the African continent. And, number one, I think the most important takeaway is that there's really a paucity of studies at all. And in fact, I think one of the biggest things about studying and understanding the burden of disease of stroke on the African continent is just that there are no studies. I mean, we really don't know from a public health perspective, from an accounting perspective, what exactly is the burden of disease. There's evidence suggesting that the case fatality rate is much higher on the African continent compared to the rest of the world. But really, I would say that it's very hard to pinpoint whether that mortality rate is really due to a construct of lifestyle factors, as it is the case with the Western Hemisphere, or is it due to a lack of access of care, or is it due to a lack of proper accounting of epidemiological numbers, right? And so really what this shows is that the burden of disease of ischemic stroke, in Africa as a whole, is wide open. I mean, in terms of really even understanding and characterizing what the burden of disease is, and then subsequently to identify what in fact is the best way to treat it, right? in other words, are people doing poorly because they can't get care for stroke? Are people doing poorly because of they have poor risk factor modification, right? Or are people doing poorly because we're not accounting correctly what numbers of people are actually having strokes versus heart attacks versus ischemic versus hemorrhagic stroke? So there's a lot of barriers there. And then fundamentally, what the other thing is to understand is that the extrapolation between stroke and the sort of that the access and the healthcare outcomes that sort of African Americans have versus indigenous Africans are not, in fact, should not and cannot be conflated with one another. And that obviously, and I'm kind of preaching to the choir here, but that many of the studies that are done that are held as quote unquote level 1 evidence are conducted in populations that are in fact not representative of, number one, the minorities that exist in America today. And that involves, of course, African Americans, that involves, Hispanic Americans, Asian Americans, and not to mention the fact that, in fact, Asian Americans or African Americans or Hispanic Americans may not, in fact, have the same sort of risk factors that the indigenous populations might have. And so whether or not, a randomized controlled trial that is held in America or in Europe might be extrapolatable to all citizens of that country is, number one, hard to say. And whether the outcomes of those patients in that country can be extrapolatable to other countries around the world remain sort of to be seen, if you will. So, that's another area that I think bears repeating before we talk about the rest of all this, right? And so keeping that in mind, right? Keeping that in mind that, in fact, most of the data that we're looking at today is really comprised from a very sort of Eurocentric and sort of, Western Hemisphere heavy, line of investigation, right? Here's what we do know about ischemic stroke. So certainly, the basic fundamental pathology underlying ischemic stroke, is the lack of delivery of oxygen, nutrients, and blood to an area of the brain. And so when we think about mammalian physiology, our brains do not metabolize, all sources of energy, right? So, in medical school, perhaps you've learned that, we can intake, and utilize carbohydrates, right? We can utilize proteins, and we can utilize fats, right? Like those are our big sources of energy. And that through processes of like gluconeogenesis and so on and so forth, the proteins, the fats, and the carbohydrates can be converted from one unto the other, depending on our various nutritional states. The brain, however, is very special in the sense that the brain does not utilize, anything essentially except for carbohydrates, right, in its simplest form. And so, the brain really is one of the highest organ metabolizers of glucose compared to anywhere else in the body. When you look at sort of the causes of ischemic stroke, really Embolism, which is, a clot forming elsewhere and going to the brain, is the most common, cause. But whether it's the vessel in the brain or something that travels to the brain, the occlusion of the blood vessel will disrupt blood flow to the brain, and that eventually causes, brain death, essentially. And that's essentially what you're looking at on the picture over here. Black is bad, essentially. And, and ultimately, with long enough sort of tissue disruption of blood flow there, the brain will eventually die. And so when we think about what are the cellular processes that underlie ischemic stroke, you have to realize that neurons are extraordinarily sensitive to oxygen and glucose deprivation. And so essentially the area that's furthest away from oxygen and glucose is the area that dies first. And, when we measure amounts, in you or me or anyone who's functioning normally, the amount of oxygen that's getting to the brain is around 100 grams per deciliter. If that decreases from 100 to around 30, you start to have neuronal dysfunction, where the neurons are not working, they're not firing the way that they should be normally for your higher brain processes to function normally. But the neurons are not dead yet, and if that number falls from 30 to about 8 or less, then you will encounter irreversible neuronal death. So in the brain, remember, the thing to remember is not that sort of one blood vessel supplies one area of the brain. It's important to remember that, in fact, the blood vessels of the brain sort of all are dependent on one another through very small capillary feeds and what we call collaterals. And so as one area tends to fail, another area tends to step in. But that can only occur up to a certain extent, right? So if you have an area that is not getting blood flow, the surrounding areas can try to mitigate that, right? By increasing perfusion to the area that's lacking blood. But ultimately, that's not forever. And if the collaterals fail, then you're going to get irreversible stroke damage. And essentially, as the cells start dying, they die via a whole host of necrotic, apoptotic, and excitatory, mechanisms that sort of we can leave for, another day. But suffice it to say is that, glutamate, is very, very important in this sort of excitotoxicity mediated cell death. And essentially you have a giant influx of calcium, and that calcium is really the first step amongst many that causes depolarization of the neuron, that causes loss of the membrane potential. That's very important for neuronal survival and neuronal activity. And that ultimately that excitotoxicity causes cellular depolarization, causes free radical production, causes all sorts of cellular debris to be sort of released into the bloodstream and into the brain, surrounding brain. And that release actually will cause a giant wave of neural inflammation, all of which the mechanisms are not 100% clear. But certainly the neuroinflammation cascade is thought to compound and worsen the damage caused by the initial ischemic damage caused by the actual deprivation of glucose and oxygen itself. And certainly right now in the laboratory, there are many labs investigating sort of the specific mechanisms of neuroinflammation in the brain. And there are translational work, even as we speak, to see if we can decrease the amount of neuroinflammation in the brain after stroke in order to, to limit the amount of stroke damage. So when you think about ways to prevent stroke, it really is centered on sort of risk factor modification, right? So that means that if you have high blood pressure, you need to treat your high blood pressure. If you have high cholesterol levels, you need to treat your high cholesterol levels. If you have, if you're smoking, you need to stop smoking. But for patients who have had strokes, they can be put on antiplatelets, such as aspirin. For people who have had an acute stroke, they can be put on dual antiplatelets, such as Plavix. These are indicated in patients with significant risk factors. Now, if you are having a stroke, really the only FDA approved medication that literally can be given in the middle of stroke is tissue plasminogen activator. And that was approved by the FDA in the 1990s. And really, it's the only FDA approved medication to treat stroke really in the last 50 years. And TPA, which we'll talk about in a little bit, is a very, very powerful sort of clot busting medication. And so, as Nancy will tell you, as she's spent many a time in the angio suites, TPA is unbelievably powerful. I mean, when you give people the full dose of TPA, they cannot form a clot worth anything. And these people will oftentimes be bleeding from their gums. They'll be, bleeding from their mouth. Some people will be bleeding from their eyes, other mucosal surfaces. If these patients have a Foley, people will be bleeding from the bladder. I mean, there's not an insignificant number of times where people come in and they get TPA and literally their Foley gets clogged with blood clots because they're literally urinating blood. So there's a lot of morbidity associated with giving TPA. And to that end, there's a lot of contraindications to giving TPA. So, obviously, if you're already bleeding when you come in, you can't give TPA. If people have already have had a stroke beyond 4.5 hours, people are afraid of that TPA will cause something called, it can cause a hemorrhage in the stroke. And so, or if you have recent surgery or any of these things, you can't get TPA. So really, only a very small population of patients who come in with strokes are even eligible for TPA. So the other things that we can do for stroke for people who have had a completed stroke is that really we're trying to control secondary damage. And so what I mean by that is, for example, when the brain dies, it undergoes massive cytotoxic mediated swelling. And that swelling occurs from the moment that you have irreversibly damaged brain up to about 96 hours after stroke. And so, a teaching point for the medical students or ones, the residents are that, ischemic stroke results from cytotoxic cerebral edema and not vasogenic edema, and therefore it is not responsive to steroids. And so TPA, we talked about it, right? It's known as alteplase. Blood clots really formed from aggregated and activated platelets that are woven together into fibrin network. And TPA really is one of the serine proteases that causes the breakdown of these clots. And so what we're really doing by giving tissue plasminogen activator is we're promoting the breakdown of clots. And one of the things that one should remember from all this is that everything in human biology is kind of like an equilibrium. So when we're talking about a clot, right, we're not talking about like a static lesion, right? A clot is constantly forming and promoting more clots. And at the same time, there are mechanisms in the body that is actively breaking down the clot. And so when we talk about like something like, there's clot, it's not really an accurate statement. What we really mean is that the processes by which clotting is occurring is greater than or equal to the processes that are breaking up the clot. All right, so that's something important to keep in mind. And so when we deliver TPA, what we're really doing is we're hastening the clot sort of degradation pathways, right? We're not actually addressing the clot forming pathways, right? And so this is a schematic diagram of where TPA is working. And for those of you who are taking hematology or have taken hematology, you know, they'll go into great detail about all the clotting cascades and where TPA fits into all this. So like I said before, TPA has a host of contraindications, right? Because it can be so morbid. So if you've had any prior intracranial hemorrhage before, you are not eligible for TPA. If you have a vascular malformation or even a brain tumor, which we know by definition sometimes can bleed, you are not eligible for TPA. If you've had another stroke within the last 3 months, you are not eligible for TPA. If you've had any kind of carotid or other arterial disease, such as a dissection or something like that, or iatrogenic injury, such as recent surgery, then you are not allowed to receive TPA. If you have any bleeding diathesis, and that can be iatrogenic, right? So in other words, if you are taking other blood thinners, such as Coumadin, right? Such as Xarelto, such as Eliquis. If you're on any other blood thinners, then you are not eligible for TPA. And of course, there's a host of other relative contraindications, which again, the take-home message from all this is that the people who actually are eligible to receive TPA are really a very small fraction of the total number of people who come in with ischemic stroke. And so, you know, if a patient comes in with a completed stroke, what are you going to do for them, right? The truth is that for the brain that's already dead, there's not much. So what you can give is that, you know, you can try to, you know, give things that control intracranial pressure. So, you know, if the patient is very sick, you can have them intubated. You can hyperventilate them, and that will result in cerebrovascular vasoconstriction and decreased ICP. You know, mannitol is not effective for long-term ICP control. So if they're having a crisis, you can give mannitol, but again, it's not a long-term solution. You can give hypertonic saline, and that will sort of pull free water out of the edematous brain. And, you know, you can have patients, you know, our normal sodium is around 140, but we can increase that sodium up to 160 even, although that tends to be the end of the line. And so, unfortunately, despite all of these medications, all of these medical managements, right? These interventions that we do sometimes are not sufficient. And so what that means is that despite giving mannitol, despite hyperventilation, despite giving hypertonic saline, and all these things, that brain swelling from the dead brain continues to push on the good brain, right? And if that brain pushes on the brainstem, you're going to die. And so if that happens, then you can perform a hemicraniectomy. And that's basically removal of the bone over the dead brain. And as Nancy will attest to, a hemicranie is not a pretty surgery. It is a life-saving operation. The goal of the surgery is to get the bone off as fast as we can so that the dying brain can herniate outside of the skull. As anyone who has seen a hemicranie will know, you know, it is absolutely like, you know, everybody's working as fast as possible to try to get the bone off. And as soon as the bone is off and the dura is open, we're closing skin immediately because the brain is just so full and it's pushing out. And, you know, if you don't close quickly, you can potentially reach this point where you literally can't, like the skin won't close because the brain is so full. And so there have been actually not double-blinded, but randomized trials for patients with large MCA strokes. And what we show, and what the trials have shown, is that hemicraniectomy absolutely 100% improves survival after stroke. And that's been one of the biggest things that people point to in terms of doing in terms of doing a hemicraniectomy, right? Is that, you go and the family is distraught. They're like, oh my gosh, my loved one was normal. And then all of a sudden now they're on the brink of death. How can this be? And you tell them, well, I can perform this procedure for them and it's gonna, as you can see, it more than doubles their chance of surviving. Presented with these statistics, almost everyone will say, yes, do the surgery. But what this graph doesn't show, and what I think is a nuance of practice that a lot of people don't appreciate at the beginning parts of training, is that the people who survive a hemicraniectomy oftentimes are neurologically devastated. So in other words, they're alive, but for a person who has a left-sided stroke, they'll never again move their right side. They're aphasic, so they can't communicate. They can't express themselves. They may not understand what's being spoken to them. And because of that, they're not able to swallow. And so they may not be, and because of that, if they can't swallow, they need a G tube. And because depending on their consciousness, they may also not be protecting their airway, in which case they need a tracheostomy. So even though the vast, you can see that the hemicraniectomy improves survival in a group, the vast majority of these patients are severely disabled. And in fact, very, very few families understand and appreciate that. And I think a nuance of practice as one grows, as one practices more, is really having the family understand what the long-term implications of stroke survival are, right? Which I think is a nuance. So, that was pretty much all you could do for a patient with a stroke. Essentially, if a patient came in with a completed stroke, that was it. You could remove their bone and hope to prevent a secondary stroke, but there was nothing that you can do for the existing stroke. All that really changed in 2015 when there was 5 randomized controlled trials looking at endovascular treatment of acute stroke. And in 2015, in 5 landmark papers that were published in the New England Journal of Medicine and the Journal of the American Medical Association, for the first time, you could show that essentially by acutely removing the clot that is preventing blood from getting to the brain, that patients actually did better. And that was an unbelievable seismic shift in how we view stroke. And the Mr. Clean trial looked at 500 patients, assigned to a endovascular care group and standard of care, which essentially was doing nothing, right? And it looked at the modified Rankin score, which is kind of like a neurologic score of how people are doing at 90 days. And what it basically showed was that if you pulled the clot out quickly, that patients were much more likely to return to functional independence. And I want to reemphasize that, right? This is not the same as a hemicraniectomy. When we're talking to patients, we're talking about survival, right? For these patients, we are talking about a return to functional, returning to actually being able to, for example, go back to work, being able to go drive a car, being able to go grocery shopping. This is a totally, totally different outlook for these people. And here is a schematic diagram showing that. And this is the modified Rankin scale score. And, for those of you who are not familiar with the score, essentially 0 is you or me. You and I are 0 because we're perfect, right? Like we're functional adults. And the worst score is obviously 6, and that's death. And so what you can see is that, up here, patients who had mechanical thrombectomy were significantly able to do better compared with people who underwent control intervention, right? So you see that, the people who were MRS score 6, those didn't change, right? And so what that tells you is that if you had bad enough of a stroke where you were going to die anyway, mechanical thrombectomy is not going to help you. You're going to die anyway. But for the people who had a chance of getting better, the mechanical thrombectomy greatly increased the proportion of people who were able to achieve a modified Rankin scale of 3 or less, right? That was the power of mechanical thrombectomy. The ESCAPE trial looked at patients up to 12 hours after symptom onset. All of these trials excluded people with a large completed stroke, because you have to remember when these trials were happening, people were desperate to show that mechanical thrombectomy made a difference. So they really cherry-picked the people who were most likely to improve. And so in a little bit, you can think of it as that, the results that you get from this trial is pretty much, as good as you're going to get, so to speak. And once again, they showed that endovascular intervention significantly increased the chance that you were going to have a modified Rankin scale and/or score greater than 3. I mean, look at this cutoff here, right? That you're talking about, these are the group of people with good outcomes versus these are the number of people with good outcomes. It actually turns out, and by the way, this was true whether or not you had whether or not you got TPA or no TPA. So this effect that you had with thrombectomy is independent of whether or not you got TPA or not. And so that was really powerful, right? So it's not like if you underwent mechanical thrombectomy, you couldn't get TPA. And to put that into perspective, guys, I really want to emphasize what a landmark change this was. So it turns out that from these trials, and Extend 1A, or Extend IA is actually another one of these trials. It's selected for patients with anterior circulation receiving TPA with less than 4.5 hours since symptom onset. And again, you had to have a small ischemic core. In other words, the brain that was dead had to be less than 70 cc's on CT perfusion imaging. And once again, you saw that endovascular therapy did significantly better, did so much better, right? So your modified Rankin scores of, less than or equal to 2 were so much better compared to the alteplase only group, which is essentially the standard of care. To put that in perspective, the number to treat for patients with mechanical thrombectomy, in other words, the number of patients you have to treat in order to help someone, is basically 2 to 3. So in other words, for every 2 people that you treat, you're able to help 1 person. And I know it's hard to put that into perspective, but certainly we know that we treat everyone with high blood pressure. But have you ever thought, what is the rationale for why we treat blood pressure? Like, why do we care about treating blood pressure, right? We treat high blood pressure because we want to eliminate the bad downstream effects of high blood pressure. So what is that? So that could be stroke, that could be kidney disease, right? That could be peripheral artery disease. All these things are secondary to high blood pressure. So we treat everybody with blood pressure, but how many people do we have to treat with high blood pressure to prevent someone from getting secondary organ injury, due to high blood pressure. That number, by the way, is 1 in 200. So we treat 199 people needlessly to save one person from the bad effects of high blood pressure. So when I say that mechanical thrombectomy has a number to treat of 2, that is truly, truly remarkable. So Swift Prime was another one of these 5 New England Journal of Medicine trials. Again, it looked at patients of stroke receiving IV TPA and the anterior circulation. And here, instead of 4.5 hours, they selected for people within 6 hours. And once again, you can see that people had significantly better modified Rankin scores, but significantly better compared to medical treatment alone. And now, the REVASC trial, for the first time, increased the amount of time. So remember, the time cutoff for TPA was 4.5 hours. And the reason for that is because beyond 4.5 hours, people are afraid that you're going to get hemorrhagic conversion. And so when we first started doing mechanical thrombectomies, people were very afraid that revascularizing a brain that was already dead was going to cause these fatal hemorrhages. And the REVASCAT trial really pushed the boundaries for how long people could be having a stroke for. And so, the question was, well, at 8 hours, if people have been having a stroke at 8 hours, can they still receive benefit from mechanical thrombectomy? And essentially the answer is yes, right? A resounding yes. And so, it's important to understand that despite all of the trials that we spoke about, that they are still cherry picked, right? So we've only done trials in people with anterior circulation strokes. We haven't done trials with people with posterior circulation strokes. And we have not addressed people with large ischemic cores. And so the trials that we've looked at up until now are really looking at sort of like the healthiest stroke patients, the patients that are most likely to benefit, right? And so, and what's very important for this talk here is that this endovascular treatment, right, for stroke is incredibly expensive. Every catheter that is used is $1,000, $2,000 US dollars. The stent retrievers are thousands of dollars. The penumbra pumps are thousands of dollars, and each one of those things are one use only, right? So these catheters are not like operative instruments that you can reuse, can sterilize, and so forth. Every single catheter that you put into the patient, every single stent retriever that you put in the patient, every pump that you use, gone, it's thrown away at the end of the case. So we have to be thoughtful about how do we bring these novel treatments to all corners of the world. So certainly, moving forward, within the last couple of years, the Dawn trial was looking at patients with, a core mismatch between 6 to 24 hours. And, it showed once again that these people, despite having larger cores, as long as they had a significant mismatch, that these people still did significantly better. And that's really remarkable. So, there's always some hips and bumps. There was a trial in 2021 that looked at the posterior circulation that didn't show any difference in terms of posterior circulation strokes. But I think despite that, people will continue to do them because if you have a basilar occlusion that you don't revascularize, the outcome is death, essentially. And essentially anything is better than death. And so, I think people will always try, right? Because not trying equals essentially 100% guaranteed death. And so right now there's, trials looking at how big does the core infarct have to be before you're not able to get any benefit, essentially. And there are trials that are being conducted around the world, in Japan and other places, that are really seeking to answering these questions. And there's always other things that people are looking at, like hypothermia, oxidative stress, neuroinflammation, that people are trying other mechanisms, other pathways that may help limit stroke. So, big thanks to the whole cerebrovascular group here, to the medical students who are working with me, just seeing if anybody have any questions.
I'm still here. Our flight hasn't left yet, but obviously, it's a great presentation, Dr. Zhu, and I really appreciate you spending the time and talking with us. And I will see other questions first, and then go from there.
Hi, thank you, Dr. Zhu, for a very great presentation. I really appreciate the overview. It's interesting to follow the progresses in stroke care. I am very interested in knowing your perspective regarding all the technological advancements we've seen in endovascular management for strokes, and what you believe would be the next frontier for the endovascular treatment of ischemic strokes.
Yeah, no, I think that's a great question. I think, without getting too much into the detail of it, but yes, I mean, there's so much research going on in terms of what are the best catheters to use. You can imagine if you have a plug up here and you're sucking down it on here, you can potentially break up the clot, and the little clot can go flinging downstream. And so people have been inventing catheters with balloons on them to arrest forward flow while we're sucking, to maximize the chance of us sucking the clot without losing bits and pieces of it or downstream. People have been inventing different sizes, different shapes of stent retrievers. People have been doing combinations of stents and suction techniques to try to best remove the clot. People have been giving local doses of TPA to try to liquefy the clot in order to better get the things out. I mean, there are so much ongoing in terms of technological improvement of how to best do the thrombectomy, if that answers your question. From a catheter perspective, from a device perspective, from a combined technique, single technique. I mean, so many things. Yeah.
Yes, absolutely. Thank you. And then another one that I believe we will all be interested in, especially being given the context in Africa, is definitely from we know we don't have enough information, obviously data or publications regarding stroke, whether that's the monitoring of patients or identification. Do you know if there are ways maybe of setting up an information management that could rely on things, I don't know, whether it's artificial intelligence, anything new, that will probably be an interesting pathway for countries or institutions looking to follow up more closely their stroke burden?
Yeah, I think that's a great question. I mean, I think, and Nancy, please feel free to jump in, because you're the one who is a world expert at sort of international sort of public health and all that. Because as you indicated, I think it is extremely challenging to really understand the burden of disease when culturally there may or may not be there may not be an established cultural practice of necessarily, number one, even recognizing what a stroke looks like, right? I mean, I would say that 50 years ago in America, I would say the average person was not educated on how does a stroke look like, right? And so I think there's a lot of people who may be passing away from stroke, but like nobody has any idea that they were passing away from a stroke, right? In other words, how many people are just passing away at home and not even making it to medical attention, right? So I think, it's so hard to, that's why, to answer your question, right? It's not something that can be done by one person. It's not something that can be done necessarily even from the top down, right? You cannot go into some country, right, and say, like, with a wave of a hand, like, we're going to document all strokes. How are you going to do that? Do people trust the healthcare system? Do they know to bring in the people into the healthcare system to receive care? Do they know the signs and symptoms of a stroke? Do they even know that that is important, that warrants medical attention as opposed to, other things, right? Do they have access to that healthcare? If someone is having a stroke, what's not helpful? A hospital that's located 60 miles away. That is not helpful to a person that has a stroke, right? And so if you are in a place where the people who are having a stroke, their closest healthcare place, right, is 100 miles away, this whole talk about endovascular, about treating someone within 4 hours, 6 hours, 8 hours of stroke onset is completely irrelevant to that population, right? And so what's going to help that population is education about what a stroke looks like, education about modifiable risk factors, about identifying what are the things that can prevent stroke, right? And ultimately to improve the health infrastructure. And so that process, and Nancy, please feel free, is much more than neurosurgery, right? That is public health. That is primary health care. That is interfacing with the patients at a face-to-face, avenue that is so far, in my opinion, removed from neurosurgery as we know it in the West, right? That's my honest, that's my take on it. That's my opinion. It's more than one person.
Yeah, no, amazing. Maybe the last one from me. So giving your background with like neuropharmacology, and I guess you probably see a lot of patients with on the multiple drugs. I think it's called polypharmacy. And like, how do you manage these patients? You mentioned the good, the bad, and ugly, for example, something like TPA, right? So can you give us a bit of insight onto how to manage some of these patients with multiple drugs?
Oh yeah, I mean, I'll tell you the short answer is that as a neurosurgeon, mercifully, I don't have to manage a lot of that. It's actually usually the critical care attendings and the neurology folk who has to manage the polypharmacy. But it's absolutely true. I mean, and the fact is, if I had a nickel for every single time somebody came in with a stroke because they were on a blood thinner they were supposed to be taking and they didn't take it, either because they forgot to take it. I mean, I had one lady who said, she said a blood thinner make her feel depressed. So she just decided to stop taking the blood thinner by herself because she said, I feel better off the blood thinner. Then she had a massive stroke. I mean, this is exactly to the point. I mean, so much of stroke, the true treatment of stroke is how do we prevent stroke? What Nancy and I are doing, right, is not ideal, right? Like when we are waking up at 3 o'clock in the morning to pull clot out of someone's brain, I mean, our backs are to the wall, right? I mean, it's like, if we don't do this, the person is going to die. I mean, that is never a great place to be.
Yeah, thank you so much. And it further emphasizes the need for robust primary care, and that's definitely something that I think everybody has taken as a lesson here. I think there's a question from Lorraine. Oh, Nancy, go ahead.
Yeah, sorry. Hopefully you guys don't hear the instructions from the client, but one of the things, again, excellent presentation and answers, Risheng, and I'm not an expert by any means, but one of the other things that I think you probably make a note of is the post-stroke care that we have, that we are actually very fortunate to have in the US versus other countries, right? Like, you have ICU care, you have rehabilitation, you have people who are getting treatment management of their stroke and acute and acute setting. That makes there's doing the primary treatment makes a huge difference and sets up to be able to take hopefully the minority of patients who end up needing.
Yeah, Nancy, I really agree with you. I mean, and that's a very good point. I mean, I've only so far spoken about getting the patient to the hospital. But in fact, after you arrive at the hospital, we talk about these fancy catheters and all that. But the fact is, that's step one, right? To do a lot of these procedures, the patient has to be intubated, has to be sedated, and all that. Is there a healthcare infrastructure system to deal with patients after they've had a stroke? I mean, many of these patients have a long and rocky road ahead of them, whether they need a G tube, a breathing tube, I mean, so on and so forth. I mean, if that infrastructure is not there, then it's a moot point to talk about mechanical thrombectomy, if that makes sense. So I think, as we think about stroke care, it's always exciting to hear like, oh, these trials or whatever. But when in fact, making sure that people have access to those things are oftentimes the biggest battle that people face around the world.
Well, thank you so much. It's been really a fantastic presentation, and we appreciate that you found the time after a case to come and give us this fantastic overview of stroke care. We don't want to take any much of your time, and we hope that we can set up something soon. And definitely congratulations on your future career at Hopkins. We look forward to reading some of your work.
Thank you so much. And thank you, Nancy. Thank you, everyone.
Thanks.